Yeah, is my presentation visible to all?
Yes, sir. Yes, it's visible.
First of all, good evening, everyone. I thank Bayer for giving this opportunity to discuss this presentation today. So, today's presentation is upon breaking barriers in metastatic HSPC doublets. Daratumumab plus ADT leads the way with Aronet. So this is a disclaimer. This is presentation was given from their side to me. I am presenting this presentation over here. So these slides are prepared for scientific and education purpose only, and for presentation to RMP and healthcare professional. And these are other disclaimers of this presentation. So just preparing for the this presentation. Just a minute, I have just missed you. So the standard care, um, the standard care in metastatic HSPC has evolved to combine ADT with AR inhibitors, abiraterone, or docetaxel. So we have seen initially stamped arm C, docetaxel plus ADT, and before that started docetaxel plus ADT, and then stamped arm C, docetaxel ADT, then latitude, then stamped arm G, and Archies, then Titan, then Enzamet, and Peace. And Arasens had come, Aranaut had come, and Arsec had come. So, despite treatment with ARPI and ADT or docetaxel plus ADT, a large proportion of patients with metastatic HSPC will progress to metastatic CRPC within 3 years. An unmet medical need remains for efficacious treatment that offers a differentiated and improved safety profile for patients in MHSPCC without adding significant toxicities and with low drug-drug interaction potential. So, Arasens, which was a phase 3 study in combination with docetaxel, already showed beneficial efficiency and safety profile in metastatic HSPC, leading to its approval in India in 2023. Darolutamide is combination with ADT, provides efficiency benefit, favorable safety profile in metastatic HSPC patient as demonstrated in global phase 3 study, Aeronaut trial with significant Indian patients. With Aeronaut data, Darolutamide has the potential to change the treatment paradigm, as now it would be the only ARI which could be used with and without chemotherapy. So coming to the background, darolutamide and ADT with docetaxel is standard of care for metastatic HSPC. In Arasens, darolutamide, ADT, and docetaxel demonstrated favorable efficiency and safety versus ADT plus docetaxel in patients with MHSPC. Aeronaut was designed to evaluate darolutamide plus ADT versus ADT to provide new treatment option for MHSPCC without docetaxel. So this is a randomized double-blind placebo-controlled phase 3 study, Aeronaut study design. It is a double-blind phase until primary analysis. Total number of patients included were 665. Um, Obviously, histologically or cytologically confirmed adenocarcinoma of prostate. Up to PS2 patients were taken. Certification factors included visceral metastasis, which were assessed by central review committee whether it is present or absent. Prior local therapy given, yes or no. Randomization was in 2:1 fashion, with darolutamide being 600 milligram BD plus ADT versus placebo plus ADT. The primary endpoint included RPFS, that's a radiological PFS. Secondary endpoint being OAS, time to initiation of subsequent anti-infective therapy, time to CRPC, time to PSA progression, rates of undetectable PSA, time to pain progression, safety. Adverse event were reported as per CTC5. Other pre-specified endpoints included PFS2, time to subsequent skeletal events, time to detection on FACT P total, time to first prostate cancer related invasive processes. This was open label darolutamide and 100% crossover to open label darolutamide was allowed open until final analysis. And then select endpoints after this were OS and safety after a data cutoff point of June 7, 2024. Median follow-up of darolutamide group was 25.3 months, placebo group was 25 months. Coming to the demographics and clinical characteristics at baseline, you can see in this presentation that the median age in both the arms were more or less 70, the same. And Asian population, where almost 1 in 3 was Asian, it is 33% of the population was from Asia. Um, you can see ECOG PS0 was 50% and 1 and 2 were over 50%. And there seem to be balance in both the sides. Metastasis at initial diagnosis, de novo or recurrence. So de novo were more as compared to recurrence. And disease volume, if you see high disease volume, there were almost two-thirds of patients or more than two-thirds were high volume disease. Missile weights were low, that is 12%, but without missile weights were 18%. And these are the some important demographic and clinical characteristics at baseline. Here is the country representation across breakthrough clinical trials for prostate cancer treatment. You can see over here that COVA trial 30 trial did not include much of the patients from any patient I think from India. There might be some patients from Indian ancestry. Vision trial and Embark trial same. But you see Aeronaut trial 30% Asian, Latin American, 29% Europe and rest of the world were 41%. So India in the region, if you see what it presented was around 61% patient in darolutamide arm, 62 patients, and placebo it was 32. It was balanced. It was 13 to 14% of the patient in both arms. So darolutamide plus ADT significantly reduced the risk of regional radiological progression or death by 46% versus placebo and ADT. So you can see over here that the hazard ratio is 0.54. That is very impressive. A hazard ratio of 0.54, placebo plus ADT. Here you can see the median PFS was 25 months. Here it was not reached, and still the line is above the median PFS. It is 70.3 versus 52.1. And median follow-up darolutamide group was 25.3 versus placebo was 25 months. The benefit here they have shown the subgroup analysis. How did this patient fare across all subgroups, including patients with high and low volume disease. So here you can see whether the age is irrespective of age, baseline PSA, ECOG PS, or Gleason score at initial presentation. This patient had a favorable response to darolutamide. And you can see when the disease volume is low, patient derived much more benefit as compared to high volume. Race also, there was not much difference. Geography wise, vessel metastasis wise, also there was no difference. Only the vessel mets, the benefit seems to be low because it is crossing the midline. But again, it's a subset analysis. We are taking in the subgroup, and this is just exploratory data, not a clinical data. And prior local therapy, you can see patient who went prior local therapy had derived much more benefit. And so, darolutamide and ADT demonstrated a benefit across other secondary endpoint as well. You can see that the OS benefit here stratified HR. If you see, there was placebo and both it was not reached, but the hazard ratio is 0.81. Time to metastatic CRPC was zero point 0.4. Here the benefit is very impressive. You can see the hazard is less than 0.50. Time to initiate, time to PSA provision, time to initiation of subsequent systemic therapy of prostate cancer, and time to pain progression. You can see the hazard ratio is very less. So OS data as was immature, but still the early signals were favorable. Since OS is immature, patients will be followed for survival. All remaining per protocol placebo patients were offered to cross over to Dalgona after primary analysis. So, despite crossover, there seems to be very favorable response in patients who were taking Bariatomide. It delayed time to CRPC as we had already seen and time to pain progression. You can see very impressive hazard ratio of 0.40. There is initial 3 4 months, it's more or less overlaps, but once after 5 months, the gap increases as the time progresses, and you can see it's a huge difference as compared to initial. And these patients they seem to derive a greater benefit as compared to placebo. Time to pain progression also in this patient seem to do better as compared to patients who were not on darolutamide at all. Darolutamide plus EDT achieved deep and durable response. So PSA of less than 0.2 nanogram per ml at any time and during treatment, you can see 62.6% of these people could achieve as compared only 18.5% in the EDT arm. Time to pain progression, you can see here that the darolutamide was doing better. That was hazard ratio of 0.31. Here also you can see a very wide separation. So 63% of the patient in darolutamide doublet arm attained PSA less than 0.2 nanogram per ml. This is represent a 69 improvement in time to PSA progression in darolutamide arm versus the ADT arm. This you can see high volume also. There's a benefit irrespective of the volume of disease. Although more low volume patient derive much more benefit as compared to high volume, but this is what is expected. The drug might work less in magnitude as compared to patient with low volume. Nonetheless, it's still a patient gets benefit. So you can see 44 versus 10.8, 47.7 versus 12.8, 50.14.2, 54.6 versus 15.5. And low volume, the difference is much more than this. Here, patient with subsequent life-prolonging cystic antagonistic therapy, what second line could be given was docetaxel. Most of these patients use docetaxel. Abiraterone associated enzalutamide in very less patient. Apalutamide obviously not a drug which is in vogue. Cabazitaxel hardly. So to basically this slide gives us an idea of patient almost 50% of this could go to second line and 45% only discontinue. Here 71.7% patient had discontinuation of second line therapy. You can see the different emergent adverse effect leading to permanent discontinuation of darolutamide or placebo. Despite placebo, there was 9% which led to permanent discontinuation, versus 6.1% in darolutamide. So, despite intervening with the new class of drug or a new drug which is a pharmacological active, the treatment emergent adverse event leading to discontinuation are actually less as compared to placebo, which is generally not expected. That shows that drug is safe. So median treatment of duration was 24.2 months in adultamide versus 17.2. Again, despite more exposure, discontinuation rates are less. The safety profile of adultamide in Aronet was independent of PSA response and consistent with the favorable tolerability first seen in RMS and RSNs. The rates of the most common adverse events were low and similar to in both the arms. Fatigue, you can see hardly any fatigue, grade 3 or grade 4 fatigue in both the arms. Basically, there is no grade 4 fatigue. Grade 3 also I'm very doubtful, but you can see both the arms, it is less. Other more or less seem to be the same in both the arms. So Daltomide extends median time to deterioration in FACT total score by 5.1 months versus placebo. And basically HRQL, health related quality of life, we measure by FACT-P total score, this method. And that one is the first and only AR inhibitor to demonstrate clinically meaningful delays in pain progression and overall healing. You can see the HR is 0.76, which is impressive, uh, especially in old, if you take into account that this is a disease of elderly patients. You can see total score is in favor of daratumide. Well-being, functional well-being, prostate cancer well-being, and urine symptoms are better. Bowel symptoms, emotional well-being, and physical well-being. Otherwise, hazard ratio is not very impressive, but T seems to be better. To conclude, daratumide plus ADT significantly improved RPFS in patients with metastatic HSPC. Daratumide showed a benefit across all secondary endpoints. Daratumide was associated with the deep PSA response, dependent of baseline PSA. Daratumide is the first and only AR inhibitor to demonstrate clinically meaningful delays in pain progression, overall well-being, including social and family well-being, functional well-being, and immune symptoms. Daratumide was associated with the deep PSA response regardless of baseline PSA, and daratumide had a favorable safety profile. Daratumide plus ADT without docetaxel should become an additional standard of care for MHSPC, especially patient with low volume, low risk, and very elderly, where you don't want to subject them to a lot of side effects of treatment, and also where you are very worried about the quality of life of patient, especially fatigue and the chances of rest. So, thank you everyone for patient listening. And I thank Bear, and I give this proceeding of this presentation to the organizers.
Yeah. Thank you, sir. Thanks for your today's time and giving this presentation to our audience. Thank you, sir. Once again, as there is no questions, we can close down this session, sir.
Oh, thank you, Teresa. Thanks. Thanks
Yeah.
a lot.
Thank you, sir.